Hello, everyone. Thank you for joining us this afternoon. My name is Rosie Mota. I am the Director of Community Health Education at the Latino Commission on AIDS. I'm broadcasting to you live from Brooklyn. Hello. And I hope everyone is in good health and safe at this time, and that their families are doing well as well. But I do want to acknowledge anyone who has been directly impacted by this COVID-19 disease. Uh, I will thank you for joining our community health forum called Addressing the Health Challenges Hispanic Latinx in New York City during COVID-19. We have four great panelists. Dr. Richard Torres will be joining us hopefully soon. I will briefly introduce everyone and we'll have a guided discussion. And afterwards we'll open it up to everyone to ask questions during the Q&A session, followed by closing remarks. And really briefly, some housekeeping. This webinar is being recorded and it will be shared. We'll have it uploaded to our YouTube channel. Please feel free to subscribe to the Latino Commission on AIDS. Please silence your microphones and write any of your questions in the Q&A box. If you go down below, you'll see Q&A. Please put them in the Q&A box and not in the chat. So I will quickly introduce our lovely panelists. Thank you so much to everyone who joined this forum, and I appreciate you for taking the time. First off, I will start with Dr. Yvette Calderon. She is an emergency medicine clinician, researcher, teacher, and mentor. She is known for her clinical research that has focused on two major health disparities in the Bronx and the Lower East Side of Manhattan on HIV and hepatitis C. Next is Dr. Susana Morales, was born and raised in New York City. She joined the Cornell New York Presbyterian Hospital faculty in 1998 and is now Associate Professor of Clinical Medicine, the Director of Diversity Center of Excellence of the Cornell Center of Health, and an Associate Director of the House Staff Training Program in Internal Medicine. And we have Dr. Navarra Rodriguez, who is the President and Chief Medical Officer for Advantage Care Physicians. Dr. Rodriguez oversees all medical leadership and health improvement activities for the practice, which includes more than 400 healthcare providers serving 500,000 patients throughout all 5 boroughs, including Long Island. And once he's able to join us, it'll be Dr. Richard Torres, and he's the Associate Medical Director of Community and Public Health at Urban Health Plan in New York City. He practices internal medicine and is a national expert in care of persons affected with HIV, hepatitis C, and those in transgender care. Please see our email of the distribution of this webinar once it's recorded, and it will have full bios of all of our panelists. So our first question will, each panelist will have the opportunity to answer each question, but I'd like to start off with Dr. Calderon. What has been the impact of COVID-19 among Hispanic Latinx in New York City?
Thank you very much, and thank you for having me this afternoon to kind of share my thoughts and experiences during this pandemic. While there were many barriers and challenges during this time, I think the most impactful barrier that I saw and that I felt was the isolation that this disease caused on the health community. COVID definitely brought to light the fact that there's so much health disparities in this country. To me, the isolation piece was the worst. If you can imagine being sick, not knowing the language primarily, knowing English, coming into an emergency department, knowing that you could potentially be admitted and not have a family member next to you. Worse than that, if you can imagine someone gasping for their last breaths at their end of life and not having someone that they love next to them or the voice of someone that they love next to them. And I think this journey that to start thinking about our communities, how we
seem to be losing Dr. Calderon. Dr. Calderon, are you able to hear us? Well,
Maybe
we'll
she'll
give
be able-
Dr. Calderon a chance to answer once, if she's able to establish her connection. Dr. Morales, would you like to proceed with the question? How has it?
Okay, yeah, I'll
COVID-19
pick up where Yvette was talking, and hopefully she'll be able to reconnect. Oh, maybe this
Oh,
is,
there she is.
okay.
Sorry, I think I
All
got
right. Go ahead, Yvette, sorry.
Thank you for
My
joining
point
us.
is that we needed to figure out different ways of having family members be their family, because you know, it's bad enough to navigate the healthcare system when you have family with you, and it's impossible when you don't. So thank you.
Thank you. Dr. Morales?
Okay. First, I just want to thank the Commission for sponsoring this forum and for all of you that are listening and hopefully participating. We'll hopefully have a good Q&A. I am a primary care doctor at New York Presbyterian Cornell, but I also served on the COVID service, on the COVID ward in our hospital for the month of April, which was the peak in New York City. And as you know, it hit New York City very terribly at that time. To date, we've had 126,000 cases in New York City, and we've had over 17,000 proven deaths from COVID since the beginning of the pandemic, and there are about 5,000 others that are likely. But in addition to that, we've had there are a lot of other people that that I think died because of unattended care. My own experience, we actually personally, clinically, was we started with a COVID clinic in March, or whatever, a presumed COVID clinic. We called it a fever clinic. And one of the huge challenges was that we couldn't test patients because of the problems with testing. So we would tell patients, we're 99% sure you have COVID and you need to quarantine, but I'm sorry, we can't test you because of the testing shortage in terms of materials. And so that was maddening for patients and for us, and I think contributed to a lot of the horrible spread of the disease. And of course, the other thing that I think that we saw and that was obvious, you know, that has become clear is that testing in the beginning of the pandemic was also not targeted to the highest risk communities, which ended up being communities of color and communities of low income. And so, and that also almost certainly contributed to the disparities that we've seen. You know, Latinos in New York City were almost twice as likely to get COVID and more than twice as likely to die of COVID, similar numbers for African Americans. And so certainly that was my personal experience in the hospital, where I saw many, many minority patients, many Latino patients, many patients, as Yvette said, that could not communicate in English. I had many bedside conversations as they were about to be put on ventilators. It was a nightmare. And we are lucky now that our epidemic is better, but around the country, of course, it's not. And the thing that we saw in New York is what's being seen around the country, which is that frontline workers who are disproportionately, here in New York, disproportionately immigrants and Latinos and people of color were the most likely to be infected and now are increasingly likely to die. So of course, here in New York, we are now facing the possibility of a resurgence, and we're scared as we're reopening, although knock on wood, it hasn't happened yet. And we can talk about what our priorities are for the future and what our recommendations are for our colleagues and our communities elsewhere later on this hour.
And I want to acknowledge Dr. Torres. Thank you for joining us. I'll repeat the question and we'll proceed with Dr. Rodriguez. The question is, how has the impact of COVID-19 been on Hispanic Latinx communities in New York City? Dr. Rodriguez, would you like to begin?
Thank you, Rosie, and thank you to the Commission for allowing me to be part of this conversation. As you mentioned, I'm President and Chief Medical Officer for Advantage Care Physicians, one of the largest specialty and primary care practices in the New York metro area, serving 500,000 patients. And with our 40 offices across the 5 boroughs and onto Long Island, I think one of the strengths of our care model is having providers and staff who come from, live in, and speak the languages of the communities that they're serving in. And I think that was a huge driver for us as we faced the COVID crisis as a predominantly outpatient practice with a large focus on primary care, but also having specialty care that wraps around primary care, things like cardiology, women's health, hematology, oncology for chemo infusions, podiatry, ophthalmology, behavioral health, endocrinology, nutrition. All of those things were important for us because we never lost sight of the fact that despite COVID, people had chronic conditions, that diabetes, hypertension, and other conditions didn't disappear because of the virus. And as a practice, we were able to quickly leverage our technology to launch virtual visits, even though we kept our doors open for patients who needed urgent critical care. We served as a practice as that landing place and place of assurance for patients who needed not only screening, testing, and management of COVID in an outpatient setting, but also we were able to continue to outreach our most vulnerable patients, to continue to look at gaps in care and try to close them, to promote vaccinations and engagement of critical care and critical testing, so cardiac monitoring, et cetera, so that patients would not fall off the map, and hopefully we could minimize any negative impacts that COVID placed before us. I think the emphasis on the community and our ties to the community was also a driving factor for us as we partnered with New York City and New York State to launch very quickly 20 testing sites. Not just testing drive-through, but testing that was tied to primary care, such that patients were screened, they could have a conversation in a language that they were comfortable in with a provider and a care team to not only get access to testing, but have their questions answered and have follow-up monitoring if there was a COVID diagnosis or a chronic condition that needed attention. So, for us, our experience has been one that has been dedicated and rooted into how do we represent our community better. How do we advocate for better access? But also, how do we leverage our technology, recognizing that there are technology disparities in our communities that have limited access to care in this COVID time, even when we're able to do fancy things with apps and Zoom and virtual visits. How do we continue to bridge that when we know that there are language barriers, technology barriers, time barriers for our communities to get the care that they need? So I think it's very important for us to have this conversation, to think about how do we promote primary care and outpatient care as a part of the system and solution to address disparities, and to, again, get focus on primary and outpatient care to help remediate that. During the pandemic, we saw a lot of attention paid to the inpatient setting, which was valid given the surge. However, at the same time that there was an inpatient surge, outpatient clinics were struggling to obtain PPE and to manage to keep patients away from those high intensity settings, even though that those patients had significant conditions. So I appreciate the viewpoints of the Commission and my fellow panelists to say, how do we learn from this experience to prepare us better from a population health perspective and a public health perspective to deliver better care to our Latinx community.
Thank you all so much for your answers so far. Dr. Torres,
Yes, can you hear
would
me?
like to add? Yes, sir.
You can hear me?
Yes.
Oh,
we
that's
hear you.
super. I'm so happy. I've been trying to get in. I got all dressed up and now you guys can't see me. So
No, we can't see you, but
unfortunately, I have a few prepared comments. I'll just read them quickly and hopefully I can address your question. So first, I'd like to just highlight some remarkable data. In the US, for example, 1 out of every 5 or 20.2% of COVID deaths have occurred in Latinos. And in New York State, where we make up about 11.7% of the total population, 15.5% of COVID deaths occurred in Latinos. And now if we talk about New York in New York City in proper, where we make up almost 1 in every 3 residents at 29.1%, Latinos have the largest total number of confirmed deaths due to COVID-19, ahead of Blacks and non-Hispanic whites. And on August 26th, I think as been mentioned by the individuals here, the CDC reported that 94% of people who died from COVID-19 had a pre-existing condition. And as we know, diabetes, for example, disproportionately affects and greatly impacts Latinos. So it really begs the question, why is our community so impacted by COVID-19? And I think that it really, if we look at Latino health status pre-COVID, it was already poor in New York City. And I think this provided a template from which COVID could decimate tens of thousands of lives. If you look at the hardest hit zip code in the city, 11368, which happens to be Corona, Queens, which is primarily a predominant Latino neighborhood in South and Central Americans. Many of these individuals are construction workers and restaurant employees, and many had to work throughout the pandemic, raising their risk of infection and transmission. I work at one site called Plaza del Sol in Corona, and we were seeing many patients present with COVID-19, including many generations, children, parents, grandparents, relatives. Many of these individuals reside in close-knit residencies and they have extended family members living in the same apartment. So these individuals would travel on the trains. The husbands, for example, may travel to Manhattan to work as an essential worker and then travel back and infect multiple generations of family members. So in Latinos, pre-COVID, they had health disparities beyond diabetes, asthma, hypertension, obesity, and behavioral health conditions. And I think all of us know now that all these risk factors are those that are very closely related to morbidity, which is of course near dying, and mortality, dying from COVID infection. So this, I think, was one of the key reasons why our community was so poorly, adversely affected. And I think I'll also say that the political climate in the US, being anti-immigrant, anti-Latino for the last several years, has caused a kind of a systematic erosion of trust in our federal government and other social institutions. So many individuals that are undocumented and Latinos are less likely to trust the healthcare system, to go out and seek care for fear that things can happen, to them. So that compounded all these variables of comorbid conditions caused our populations to have such a great impact with COVID-19.
Thank you so much for that insight. Dr. Morales?
Yeah, I just want to add two thoughts. I'm glad the issue of the fact that Latinos and African Americans, indigenous people are more likely to get COVID, largely because of social factors like being frontline workers, multi-generational households, things like that, very important. But then the fact that we are also more likely to die of COVID, some of that I think has to do with pre-existing conditions for sure, but I think it's more than that, and harder things to prove, of course, but certainly one of the concerns I have had is the issue of bias and racism, whether conscious or not, in the system and in among providers. Certainly, at the peak of the disease in New York City, for example, we were telling people, don't go to the hospital unless you're short of breath. And, a lot of people delayed seeking care. They were also terrified of going to the hospital because, as Yvette mentioned, they were afraid they would never see their families again because you weren't allowed to have visitors. And so people basically decided, many of them de facto, to die at home or only sought attention at the last breath when it was too late. So this issue, and I think that, one of the worries I think that people have is where people turned away disproportionately, especially people of color, poor people, et cetera, and told, no, you're not sick enough to be in the hospital. I know for a fact, a couple of my patients were told by EMS, you're not sick enough for us to bring you to the hospital. So there's something about a crisis condition in a pandemic where resources are limited, where people make snap decisions because the world is coming to an end, basically, and those kinds of decisions are more likely to harm the vulnerable, which is really awful. And the other, just two other things, the issue of nursing homes and how that fueled a lot of the deaths related to COVID, and I think a lot of the undiagnosed deaths related to COVID, the fact that many of those, both workers and residents of nursing homes is a really concerning area. And I think that, in an ugly part of the history, I think people weren't brought to the hospital in time, but also nursing homes weren't given access to resources. It's a mostly for-profit industry, and they run on a tight, margin, and it was basically pretty, I think, unsupervised. And I think we're seeing around the country a lot of people dying in nursing homes. And the final point is the aftermath. So right now we're hoping we won't have another surge, but the other issue now is the chronically ill COVID survivors. If you're lucky enough to have survived, now we have thousands and thousands of people that are still having sickness related to COVID.
Right. Let me start on in the second question. It is related to access to care. What are the challenges for Hispanic Latinx communities in accessing healthcare, as we know that has contributed to many comorbidities as well as deaths? Dr. Torres, would you like to begin?
Sure. Can you repeat the question again?
Yes. What are the challenges for Hispanic Latinx communities in accessing healthcare? I know you mentioned some of it before. Anything else you want to add?
I would add that there is, an issue with the fact that physicians, providers, let's say, and patients are from different cultural backgrounds. And I think more often than not, the provider is non-Spanish speaking. So for that large population of Latino patients that do not speak English, they either are not understood or partially understood, or a translator that's used that is not certified as a translator. So there's always this void of understanding exactly what the patient is trying to tell them. So I think that's a barrier when they're interacting in healthcare.
I find that so true. I think Dr. Torres mentioned this earlier as well. Trust in the system, trust in the provider, trust in that access point is critical, because without that, there is fear of going to the doctor, fear of accessing the system, fear of not being understood. And how do we bridge and build trust in our community? It does have to do with who is representing them, who is caring for them. Are they able to speak in a language that is understood? That's so critical. But I also think that we haven't done a great job in educating how to navigate a pretty complicated system. How do we go from, I'm not feeling well and I should access a primary care provider or other source and not necessarily go to the emergency room? Or how do I get coverage for what could be a very expensive visit? How do I get insured how do I manage the finances and cost of medication? And so being able to have partners from community-based organizations, from payers and others to help with that education, but also to help get coverage and access to resources will help our communities be able to seek care. And last but not least, I will harp on this, having lived through the digital transformation now. Knowing that kids have to go to school, that parents have to work, that parents, grandparents, and kids may need to access the healthcare system virtually, households that have only one device or don't have internet access are going to be challenged. And so we will need to be able to think about access in addressing social determinants like technology, like education, and building that trust and ensuring our healthcare workforce represents the people that we're serving.
Thank you. Dr. Morales?
Can you hear me?
Yes.
Okay. The access issues in terms, access has many components, and one of them is health insurance. Of course, Latinos are the ethnic group most likely to be uninsured. And now where we have about 1.5 million people that have lost their jobs in New York City since the beginning of the pandemic. That number is going to potentially go up. We have, so I think one of the things that the pandemic has forced certainly us and the country to look at yet again is the importance of universal health care and universal health insurance. But certainly in the short term, until that can hopefully happen with the new administration, there are crisis interventions that have been done in the past. For example, after 9/11, there was presumptive Medicaid eligibility. That was partly because of the destruction of all the databases, because that's, the Medicaid databases and their computers were where the Twin Towers were. But that same methodology could be used. It was a way to massively expand health insurance to New York City, and I think it should be done again. And it's a model that other parts of the country should consider, because the economic, the COVID has not only affected people's physical health, it's also obviously affected their economic health. And so presumptive eligibility for health insurance like Medicaid. But the issue I think about all these things is we need to think big. That's why universal health insurance. Navarra mentioned the digital divide. Broadband should be a public utility and a public benefit, and something that is universally accessible. I think we've learned from this that there's no way that we can, that it's the disparities in education and healthcare access and everything else are so huge that that it just cannot be allowed to continue anymore. And just like electricity became a public utility, and there was a national effort to electrify the country after, around the time of the Great Depression, we need to have the same approach now in terms of broadband. I'll stop there.
Thank you. Dr. Calderon?
Yeah, I just want to underscore one thing again. This digital divide, I think, is huge. Navigating the new system of healthcare, where the old system was horrible to navigate. This one is equally cumbersome and creates quite a bit of barrier that I've seen for patients that have come to the ED, who we do follow-up calls with, and who say, well, I couldn't get on to my digital telemedicine, check-in point. What do I do now? One of my biggest concerns with respect to accessing care is that I think our communities are really concerned about getting COVID if they come into the healthcare environment. They're just petrified of going back to a clinic or to the emergency department. The volumes have gone down dramatically, yet what we're seeing, at least in the emergency department, is that those patients that do come in, they're coming in much later in the course of any of their disease processes. And that is, creating even more of a disparity, I think, where if you're having chest pain, you decide not to go in and try to figure out what this is all about because you're concerned about going into the healthcare environment and getting coronavirus. I don't think we've done a good job in educating our communities, letting them know that we're mitigating those issues of contracting coronavirus within our settings, and that we've worked very hard to do that. So yeah, that's one of the fears that I have for our community, that they fear the healthcare community now and see us as a place where we've been taking care of all these patients, at least in the hospital settings. So.
Well, thank you all so much for everything you've shared so far. We appreciate your knowledge. For these next two questions, we can keep it to brief remarks, and then we'll move on to the opening of the Q&A. And please feel free, everyone, to write your questions in the Q&A box. If you wrote a question in the chat, please put it in the Q&A so we can find it. The next question is, what are the challenges in addressing health disparities in New York City? I know we've touched on this, and I'd like to begin with Dr. Rodriguez.
Yes, and I'll take up after Dr. Calderon. One of the things that we've seen is that to address healthcare disparities, we need to educate, and we need to educate broadly and think big. One of the challenges we saw is that providers can't do this alone. Individual groups can't do this alone. It requires us to break down silos and work with partners in other venues to reach a broader patient population. So for us during the pandemic, one of our experiences partnering with Emblem Health was to have a Facebook Live town hall in Espanol so that we could answer questions about why is it important to get your flu shot? Why is it okay to seek care? Why is it safe, and what is the healthcare community doing to keep you safe when you need care and not to postpone things? So thinking about partnerships and leveraging the power of many to reach more so that our communities can have access to primary care and specialty care more reliably, I think is critical.
And next, well, Dr. Morales, would you like to add?
Yeah, I think that when health disparities are partly related, of course, to healthcare delivery, but most of health disparities are because of social determinants of health. And a lot of the social determinants of health are due to structural racism. And the irony to me about New York City, we're very proud of New York City because it has a long history of being a progressive, a center of progressive thought. But ironically, it is also one of the places in the world with the greatest amount of residential, economic, and social segregation. The healthcare system is segregated by race and ethnicity and socioeconomics. We have the biggest extremes of rich and poor. And, I think that the irony about New York City is that a lot of those extremes are compensated for by a social safety net that other parts of the country don't have. So, the thing that keeps us rolling is that we at least have something of a social safety net, but it's obviously inadequate. And what we've seen with COVID is that that's not enough. And so what we really need to be looking at is other efforts to change the social determinants, including, as many advocates are talking about, tax the rich, the issues of unemployment, the issues of rent, and the potential wave of evictions that's about to happen. All of those things need to be addressed because we may have other horrible impacts. Some of the people in the chat also talked about things like space, green space and mental health issues. And I think that is also really important. It's about prevention, about dealing with some of the mental health impact. And, things like having green space and having, dealing with environmental health issues are also part of the social determinants of health. And we are a very polluted city with very inadequate access to things like green space. We're lucky that we have a public hospital system. Many parts of the country don't even have that. On the other hand, the irony of our public hospital system is you have incredible need with inadequate resources. And our hospital system and health system in general is in the middle of a crisis because everybody lost massive amounts of money and now potentially layoffs are going to happen. and the federal and state government aren't really stepping up to help with that as they should.
And Dr. Calderon, would you like to add to the challenges in addressing?
Yeah, I guess in part, I think when I think about health disparities and the intersectionality with race and ethnicity, I think that there is a lack of data on our part within the healthcare world. And I think we have to be held accountable. I think we need to start talking about creating dashboards, health disparities dashboards within our different departments of medicine, to keep us accountable of what is happening, what is the data to support it, and how can we then intervene to make a difference at the level of the providers. Because I do think there is a sense of unconscious and conscious bias that also plays into our healthcare delivery. There's the structural piece that Dr. Morales spoke about, but I do think that we need to examine the fact that there are biases that the providers may have, and we need to get to those biases. And the only way we're going to do that is if we have data that provides us kind of the feedback that says, you know what, maybe you haven't been taking care of that population that you serve as well as you should be. And so I think that we need to hold ourselves accountable more because of the racism that exists within our own practices.
And Dr. Torres, would you like to add?
Sure. Just briefly, I would want to expand a little bit on what Susana mentioned, and I agree with all the comments by everyone. But I think we have to get a little bit more practical as well. We have to work with the non-healthcare agencies. For example, having bodegas, which are everywhere in our community, provide more options for our patients in our community. Somehow partnering with nutritional agencies and nutritionists working with bodegas, for example. We need to do something about improving our parks, making them more safe and more accessible so patients have a place to exercise and feel comfortable, and working with employers to expand healthcare coverage and also supporting our patients who have medical conditions and allowing them more time off and time to be healthy and having a healthy environment. Thank you.
Thank you so much. And our last question before we go on into our very robust Q&A going on is what strategies could you share that might improve the health outcomes of Hispanic Latinx during this COVID time? We'll start with Dr. Calderon.
So I think that, as I said before, I think some parts of it is keeping ourselves accountable with the data that we collect. I think we need to, one big thing, I think Dr. Morales touched upon this, is the fact that our vulnerable communities that were at risk were not tested. And we need to up our game in terms of testing our vulnerable communities, our Latinx communities, our African American communities. We cannot not test them because we know that they're vulnerable and we know that their mortality rates are high. So I do believe that we should be doing that. I think we were talking right before the webinar also about New York has relatively good data, but there are many of the states that don't have great data with regards to race and ethnicity, testing, infection, and mortality. And we really need that. We need transparency in this area. So I think that's some of the things that I think about when I think about strategies that could help us going forward.
Dr. Torres?
Yeah, I'd like to add that in addition to testing, I think more education is needed. And I think we have to hold our own people accountable. It's sad for me to say that I oftentimes see too many of our community not wearing masks, not practicing social distancing. And, there's a particular building in the Bronx that I go into. It's a 20-story building. And there's 4 elevators. And one of the elevators I like to call the COVID elevator, because I would hope that patients that are not wearing masks use that elevator and leave the ones that use a mask to go in the other elevators. So oftentimes I myself, when I go up to the 19th floor, I have to wait 3 or 4 elevators to make sure that everyone is masked. And so I think that's another factor, just educating our community about the importance of using these precautions. And we should keep ourselves accountable.
And Dr. Morales, would you like to add to the strategies?
Yeah, you know, I think we're seeing in New York City COVID exhaustion and some, I think, some inaccurate belief that it's all over. It's not all over. A friend of mine was just admitted to the hospital with COVID. So, you know, it's still happening, although it's better. We're right now, as we're undergoing reopening, I think going to undergo several huge risks. Obviously, the school opening is something that we're worried about, and parents are really confused about what to do. As more people go back to work and as public transit is used, that's going to potentially also add to the risk for reopening. And Yvette, you know, you said patients are afraid to come back, but which I know, but I'm one of those patients, right? Even I, a healthcare worker, have I sometimes put up some things off? Yes. So I think some of the fears are understandable, especially because I think people have been so traumatized. We are all traumatized and are fearful of the danger. I think that the contact tracing problem, nobody's mentioned it actually. You know, that was a big controversy in New York City about who should do the contact tracing and how well was it going to be done. It was done not by the New York City Department of Health, which has a long history of performing contact tracing, but was actually assigned to Health and Hospitals Corporation, which was a big political brouhaha. But my understanding is that the contact tracing process has been very challenged by people's fears of, you know, being approached, a lot of technical problems, language problems, not wanting to disclose contacts, you know, and contact tracing is the key to controlling an epidemic. So the issues of public education about using social distancing, about personal protective equipment, including masking, about contact tracing and its importance. And then it's all very well and good to tell people, oh, you should really quarantine. But time after time, when we were telling people to quarantine, there was no way that they could quarantine because they lived in a house with 10 other people. So there has to be a system in place for people to be able to be to be safe and be quarantined. And I don't really feel that that's been robust in New York, and it's certainly not robust in other parts of the country. You know, the final piece about going forward is the issue of the vaccine. We're all praying that a vaccine or more than one vaccine becomes available, but there are huge issues around trust preceding COVID about vaccines. But now, because of the politicization of this issue, because of the lies and misinformation that are all over the internet and also being peddled by the government, the trust in a vaccine and the development of the process of its development is even worse. And so I've had, just in the last 24 hours, I had 2 or 3 patients tell me I'm not going to get the vaccine. And yet the only hope I feel that we have is if the public has confidence in the vaccine. So I think the next phase is going to have to include incredibly aggressive engagement of community leaders to both monitor the development of a vaccine, to monitor the adherence to the most rigorous scientific process to protect the science behind this so that it doesn't become a politicized thing and an October surprise, and to encourage to be able for us to be able to confidently recommend to our patients that it's okay, this is safe. So, you know, this issue of misinformation and how it's in the internet and how it's being peddled by the government, we cannot minimize the gravity and the danger that poses for dealing with this in the future.
Dr. Rodriguez, would you like to close off this?
Absolutely. I was going to circle back to 2 things that Susana was talking about. First and foremost, immediately, not just a COVID vaccine. We need to aggressively vaccinate people for the flu. we can do that now. We need to do that now. But secondly, a comment you made, Susana, early on is we need to think big. We need a coordinated strategy, not siloed strategy, but a coordinated strategy on a local, state, and national level to think about how do we get flu vaccinations? How do we provide internet access? How do we ensure that people have coverage and have the ability to access care? It's daunting, but I think this is the time for us to think creatively, think big, and truly push that agenda and address face on the disparities, the racism that exist, and build something better.
And piggybacking on that, a national mask policy, a national testing policy, all the things that were supposed to happen and didn't happen, and an international policy, right? We're withdrawing from the WHO. We're withdrawing from the WHO's vaccine efforts. Our brothers and sisters, our families are in Latin America. There's no moat around America, as we all know all too well. And what's happening abroad also impacts us. And so this is a local, state, national, international.
Thank you all so much for everything you've shared. Dr. Calderon, you want to add a brief remark?
Just a brief remark. I just want to also shed light that even in Puerto Rico early on, they were not put on any list to be given tests so that they could do testing in Puerto Rico, which is a colony of the United States. So I think that, to your point of international, but if we look at our own country, there were areas that were, I think, overtly overlooked.
I think he wanted to trade it for Greenland, is what I read.
Oh.
There you go.
Well, thank you all for everything you've shared so far. I will read the questions now in the Q&A box, and whoever wants to answer can answer it. But the first one is related to something Dr. Morales already mentioned about green spaces. Our question is related around what do you see is the impact of the closure of our green spaces that happened in April and during the beginning of the pandemic? What do you see as the impact on Hispanic Latinx population in New York on not having access to those in the beginning, and the long-lasting mental health impact that could have?
I'll take just quickly seeing patients and talking about the weight gain that they had from not being able to access foods that were healthy, that were part of their diet before, not being able to go to the parks and walk as they usually did. In my practice, I'm seeing that impact as we look at diabetes control and hypertension control. Not to mention the isolation that Dr. Calderon spoke about before, people who are grieving losses of family and friends being isolated and not able to promote things that they know help their health.
I want to underscore the mental health piece because I think that's huge. And we do see quite a bit of the backlash of that in the emergency department, and that coupled with substance use because of the depression, it is it's heartbreaking. And so those are some of the impacts that I think we are going to be seeing, and hopefully we can get ahead of in terms of preventing some of this.
Thank you. Our next question is related around seeking treatment. One of the biggest challenges we have found is most of them are afraid of being targeted due to their legal status, therefore not getting tested or seeking treatment. How do you recommend we debunk that fear?
I think that's where the public health messaging has to be loud and clear. I think in New York City, there's been a very concerted effort to be clear that nobody, you won't have your immigration status asked about, that you can get testing for free. That's the other piece. It's immigration status, but it's also, since much of the country, people are saying, well, I have to, save up $130 so I can go get my COVID test, cough, cough, cough. And so it is not free in all over the country. So this whole thing of a national testing policy is really important. But it's an example of how immigration policy affects public health. If you have people afraid to seek testing and frankly afraid to not work, because if you don't work, you don't eat. That's the other way that we spread COVID. And so we're, again, along the thinking big perspective, we have to address immigration policy. But short term, it's just really important for every locality to send a message loud and clear that, no questions asked about immigration status. We'll take care of you, whatever your immigration status, just come in if you're sick, period. And then to follow through.
Anyone else would like to add?
Yeah, I'd like to say that what we've seen the last 5 to 6 months during this COVID era is, of course, we mentioned weight gain in our population. We've also seen a sedentary lifestyle, having to be indoors, not being able to, like we mentioned, going to a park, the isolation, the stress, anxiety, and depression that accompanies, meeting others and going outdoors, and even the restriction of travel. Patients, especially in New York, have quite a few family members in the Dominican Republic, in Florida, in Puerto Rico, and in other countries, and they're used to traveling back and forth somewhat very frequently. And during the last 6 months, this has not been allowed for the most part, and this has, I think, compounded our issues with our patients.
One question I would like to add is, what role do you see nonprofits playing in this crisis?
I think nonprofits can, depending on the mission, certainly be part of this advocacy team. Again, social determinants, but COVID has affected every single thing in our world. It's totally harmed nonprofits and their ability to raise money, to implement their programs, et cetera. And a lot of the issues that we've mentioned are relevant to the nonprofits, but nonprofits are a trusted source of information. So the healthcare community and the public health space need to partner with nonprofits to get those messages out about both, protecting from COVID, and then this next phase of how do you access healthcare, how do you access testing, how do you get the vaccine, is the vaccine safe? All of those things. I think the nonprofit community needs to be brought into the conversation so they're confident that the vaccines are safe, so that they can then turn around and promote that with the community.
I would agree, and just want to echo, I think nonprofits and community-based organizations have a huge role to play in addressing those social determinants of health, helping patients navigate when they have food insecurities, how they could get supports. So I think that though hard hit, as much as we can do to band together from the nonprofit, the provider world, the hospital world, the public health world, to say, thinking big together, we can pool resources to better support our communities. It would be helpful in addressing those social determinants, and then also tackling COVID testing, screening, support, and education.
I would like to add that we will be hosting more webinars in the future that will be addressing items just as addressing access to care, as well as the vaccine once one is available. But speaking of vaccines, and since we're entering the season, is the flu vaccine recommended for people over 60 years old?
I have to unmute myself fast. Yes, yes.
For everyone.
For everyone.
Person is supposed to get the flu shot, not just people over 60. Everyone.
Correct.
Great.
I think every healthcare area that people touch should be talking to their patients about getting the flu shot. Certainly within the emergency department, within our urgent care, within our clinic settings, our primary care settings, all of that are within our peri-op settings. I know that we're making a concerted effort to make sure that everyone gets the vaccine.
Just to clarify it, the issue is not that having the flu is going to make you more at risk to have COVID. The issue is that the flu kills thousands and thousands and thousands and thousands of people every year. It just doesn't make the news because it's not news. And the community is not really fully aware of that, and people misinterpret colds as the flu, et cetera, et cetera, et cetera. But every year we have thousands and thousands of people in the hospital, many tens of thousands of people that die of the flu. And there's a lot of misinformation about the flu vaccine. It's an incredibly safe vaccine. The hope is that if people are vaccinated, that decreases the overall death rate from respiratory diseases, but also decreases the burden on hospitals. Because if another surge happens, then it's going to explode again. And when you have scarcity, you have more death.
Can I just add to that, that we saw quite a bit of co-infection during the first wave of the flu and COVID. And that was, I mean, devastating to the patients that had that, the co-infection.
Thank you all so much. And I'd like to tell our attendees that we have your questions recorded, and we will get to them and answer them as we need to. And we were only able to answer these questions so far. We will move along to our closing remarks. I would like to start off how we began. Dr. Calderon.
Well, once again, I want to thank the Latino Commission on AIDS and my colleagues for giving me the chance to be a part of this webinar. I want to just encourage our participants and viewers that the hospital and primary care areas are here to take care of patients, and we should really be advocating for our patients for them to understand not to stay home and not take care of their health and their chronic issues, and certainly if something acute is happening, not to stay home because of fear, but to come in so that we can help them and educate them and care for them, because that's what we're here for. So thank you.
Thank you. Dr. Morales?
Yes, I want to thank again the Commission for hosting us. COVID-19 has brought into incredibly sharp focus our country's history of unfortunate racism and inequality, along with some of the great aspects, of course, of our country, our healthcare workers, the resilience. I don't want to only paint a completely bleak picture, but certainly the disparities have been, encapsulated in the 7 months of hell. The next steps, I think, are to work to heal, to stop the spread in the other parts of the country and the world, and then to keep this from ever happening again. And the way you do that is that you have to have a public health infrastructure that is not starved of resources as it usually is, but is actually abundant in resources, as well as all the things I mentioned about addressing social determinants and other inequality. One of the most interesting articles I read during this whole pandemic era was specifically in this issue about viruses, because it's not the last virus that's going to appear, is that there are ways that require investment to have vaccine platforms that a new virus appears, that you can devise rapid interventions with vaccines. It requires an initial investment, but it's something that I was not aware of. So I really feel like a renewed attention to prevention and to public health is really important.
Dr. Torres?
Thank you. I also want to thank the Commission for sponsoring the webinar. I want to add to what was said a little earlier and what Dr. Calderon brought up insofar as Puerto Rico being a colony. I think we should understand there is a colonial mentality that we have that exists in our community. People expect others to do for them. And I think COVID now has really hit us in the face, and we should realize that we need to make our own decisions about how to protect ourselves, and we need to educate our community that they must get the flu vaccine, as was mentioned earlier. They need to wear masks. And by the way, I've heard that globally the rates of flu rates have decreased because of mask wearing in parts of the world. So it enforces the fact that using a mask is so critical in lowering a person's risk. But again, I would say that our community needs to change their their mindset and realize that they need to do it themselves. They need to take action, protect themselves and their family members. And I think that's where the responsibility begins. Thank you.
Thank you. Dr. Rodriguez?
Yes, and I want to thank the commission as well as my fellow panelists and the participants who have been listening in and asking these great questions. It's a wonderful opportunity for us to have honest dialogue and have a conversation. But I think it's equally important for us to leave today with steps to take action, getting education out there to vaccinate for the flu, getting education out there about how to safely access care, building confidence in community-based primary and specialty care so that we can address chronic conditions and begin to engage and break down silos to address those social determinants of health. So thinking big and taking steps and action tomorrow, today, to make sure we can address on that local level, state level, national and international level. How do we protect our Latinx community, and how do we build a stronger system, not only for Latinx patients, but everybody?
Thank you all very much. Thank you to our panelists and to all of our viewers. I want to acknowledge all of you sharing your experience in the chat. We hear you, we are with you, and we think about each and every one of you every day. And we want to remind people to please complete your census. Census 2020 is still going on. Let's complete it. Also, remember to vote on November 3rd. This is going to be a big election, and especially for our community. As well as please join us in October for NLAD, or National Latino AIDS Awareness Day is coming up. And please join us on our future webinars. And please check out our YouTube channel to see our previous webinars. Our last one was on vaccine trials. So thank you all very much. We have a great afternoon, and we have your questions recorded. Thank you.
Love you guys.
Thank you.
Thank you all.
Thank
Please
you.
stay safe. Gracias.